It's very nice to meet again in Vecsés. I would like to thank organizers and Zoli. It's really very nice. It's a privilege and pleasure. And I will talk a little bit about sepsis and haemostasis beyond sepsis-induced coagulopathy and disseminated intravascular coagulation. I have no conflict of interest. And in fact, about SIC and DIC, I'm very grateful to Christian because he said almost everything. I would only remind that all cellular players in pathophysiology of sepsis, they affect, in fact, not all, but most of them, they affect not only immune response and pro-inflammatory response, but they affect hemostasis. It was shown some years ago that the monocytes are main source of tissue factor. The neutrophils and neutrophils traps activate coagulation and plays a role in endothelial injury. And if endothelium is injured, of course, anticoagulation mechanisms are impaired. Thrombin is crucial not only for the coagulation pathways leading to fibrin formation, but also they activate platelets and activates protein PAR receptors, leading to pro-inflammatory response or enhancing pro-inflammatory responses. Which is shown in this slide. And SIC, septic-induced coagulopathy, is not only pathophysiological concept, but this is also the clinical concept. And it works, I think, in two roles as a clinical concept. It is an equivalent to organ dysfunction, system dysfunction criterion for sepsis diagnosis, and as a warning sign preceding that the DIC will develop. Christian already told it is present in about 25–30% of patients, and in patients with sepsis 3 criteria without shock, it was shown that SIC increased mortality. The diagnosis is quite simple because we combined of sepsis-induced coagulopathy. We combined SOFA score with thrombocytopenia and only, in fact, a little bit increased INR. And of course, we have also clinical criteria for DAC. But to make a diagnosis, we mainly use standard coagulation tests, plasma tests, and only some of them are needed. We, of course, can measure additional markers. I will just say a few words about viscoelastic tests. So we have Rotem TAC, as you know. This is rotational thromboelastometry and thromboelastography. And there are some studies in septic patients, for example, correlating the maximal amplitude in TAC with DIC development. But to summarize it very, very shortly, if we think about hypocoagulability, we can detect hypocoagulability before the drop of plasma markers, or before plasma tests show hypocoagulability. We can detect hypercoagulability, especially in early stages of sepsis, and we can also detect impaired fibrinolysis. So here in this study, XTEM tests and XTEM lysis index shows fibrinolysis shut down in septic patients, especially with higher SOFA scores. So, it's quite specific DIC for sepsis, because this is DIC with impaired fibrinolysis. Christian already told us a little bit about homeostasis-targeted treatment in sepsis. But in fact, what we have, if we use heparin in septic patient, we still use it as a preventive doses, like in all ICU patients. If we use coagulation factors, it is in overt bleeding, and it is a little bit like pouring the gasoline to the fire. But sometimes we need to do it. And finally, replacement of natural anticoagulants. In fact, the data shows that there is some benefit only in a group with overt DIC, especially if for antithrombin is old study showing in patients who did not receive heparin, because combination heparin and antithrombin led to bleeding. And we don't have activated protein C. As regard to activated protein C, it was also shown, some benefit was shown in overt DIC in septic patients. So I'd like a little bit to change gears and to focus on platelets. And of course, we have a thrombocytopenia in many, many patients, really many patients with sepsis. We should, at the very beginning, exclude the laboratory phenomenon of pseudothrombocytopenia. And before we perform differential diagnosis, we should have some issues in mind. Firstly, thrombocytopenia does not exclude thrombosis. Thrombocytopenia might be immunely mediated by immune phenomena. Risk of bleedings does not depend only on platelets, and we should be very careful and cautious with platelet transfusions due to variable effects of platelet transfusions. And then the approach is quite simple at the very beginning. First, we should exclude DIC using criteria. Then we should look at hemolysis. Do we have elevated bilirubin? Do we have low haptoglobin? If you have, please use free hemoglobin. And if we have hemolysis, we should diagnose more in detail thrombotic microangiopathies. If we have no hemolysis, other causes of thrombocytopenia. With thrombotic microangiopathies, it's not so easy because we have overlap between DIC and TMA. From anatomical point of view, TMA is located a little bit both on the arterial side than DIC. And in DIC, we have involved, in fact, both pathways, those classic coagulation pathway and platelet activation and microvascular thrombosis. In TMAs, the platelet activation and microvascular thrombosis plays a central role, really. I loved the approach which was shown by Eli Azoulay and co-workers to thrombotic microangiopathies. So first, look at organ damage, especially GI system, central nervous system, more frequently involved in thrombotic thrombocytopenic purpura, and kidneys, more frequently involved in hemolytic uremic syndrome, but also other, plus thrombocytopenia, plus angiopathic hemolysis. This is high suspicion of thrombotic microangiopathy. Then the diagnosis confirmation. Cystocytes on the blood smear, the indices of hemolysis, direct antiglobulin test negative, coagulation tests normal in, let's say, pure cases of TMA. Then exclude other causes of TMA, which are, let's say, rare rather in sepsis, like Evans syndrome, so this is autoimmune, hemolytic anemia, and thrombocytopenia. And finally, proceed to tests. So the metalloproteinase cleaving ultra-large multimers of von Willebrand factor is low in TTP, and quite big subset of hemolytic uremic syndrome is caused by infections. So Shiga toxins, Escherichia coli, Shigella dysentery, and in pediatric population, Streptococcus pneumonia could also induce hemolytic uremic syndrome. But we may not, it is also possible that the sepsis will trigger autoimmune response to the components trigger anti-immune response to the complement system components, and can cause atypical hemolytic uremic syndrome. So in fact, majority of hemolytic uremic syndrome, if we remember about pediatric population, is caused by infections. And if when we diagnose atypical HUS, we need special treatment, plasma therapy, so TPE, and there is a now drug which we can use, eculizumab. As regard to TTP, in fact, infection can trigger each type of TTP. Immune TTP, a congenital TTP episode, and unknown cases. And there were case reports showing TTP induced by infections. It's quite interesting that the metalloproteinase ADMTS3 is decreased in septic patients, and there are some similarities. Increased platelet wall introductions are common features of sepsis and TTP, and in sepsis, we can measure very high levels of von Willebrand factors and ultra-large multimers. And a number of factors involved in sepsis pathogenesis and immune response and pro-inflammatory response may be responsible for inactivation of ADMTS13. We should remember that in TTP, the mostly involved organs are GI system, central nervous system, and cardiac system, and not so frequently kidneys. Scores can help us, but let's remember that the deep thrombocytopenia and limited kidney injury and hemolysis gives a suspicion of TTP, and we should start treatment before confirmation by the measurement of ADMTS13. We should avoid platelet transfusions, and the therapeutic plasma exchanges are the mainstay of our patient management, together with corticosteroids and rituximab, and now we have also caplacizumab. But there are also other causes of thrombocytopenia and thrombotic microangiopathies. I would like to draw your attention to one of it, which is catastrophic antiphospholipid syndrome. Antiphospholipid antibodies may cause a very severe clinical syndrome, and the catastrophic antiphospholipid syndrome is diagnosed if we have involvement of more than 3 organs by thrombosis with the presence of antiphospholipid antibodies, and usually the disease is very quick, develops during 1 week. And there are some case reports of catastrophic antiphospholipid syndrome after staphylococcal infections. And even there is a hypothesis how the autoantigen was formed to induce the immune response. And the antiphospholipid or anti-beta-2 DP1 antibodies in this syndrome. Management is quite complex because in this disease we should give HIP anticoagulant, heparin, and immunosuppression. So plasma exchanges, IV immunoglobulins, and methylprednisolone. Adds-on therapy, rituximab or cyclophosphamide. There are also other causes of thrombocytopenia, and I would like to draw your attention to one of it, which is hemophagocytic lymphohistiocytosis. I have seen during my life the cases of it induced by infections, and not only these infections you can find in a textbook. So if you have bicytopenia, high triglycerides, low fibrinogen, and very high ferritin, you may additionally measure, if it's available, soluble interleukin-2 receptors. The ferritin and this protein soluble interleukin-2 receptors level is associated with the risk of mortality. Unfortunately, it's not specific only for HLH. The treatment is very difficult. So the corticosteroids, immunoglobulins, and I have never success with really chemotherapy. And finally, sorry, I'm a little bit over time, we must think about iatrogenal causes. Antibiotics may cause both thrombocytopathy, impaired platelet function, and immune thrombocytopenia. And if they cause immune thrombocytopenia, stopping antibiotic is not enough. We should use steroids and sometimes intravenous immunoglobulins. And of course, my favorite topic, ECMO. ECMO coagulopathies needs, let's say, another talk. Yeah, but you can see it's not only consumptive coagulopathy. It may be activation of fibrinolysis via contact system. It may be acquired von Willebrand syndrome. So I will just go to my last conclusion. You can see my conclusions on the slide. The disorders of hemostasis associated with sepsis extend well beyond traditionally understood SIC and DIC. And sorry, I would like to thank you, and sorry I didn't tell anything about AI, because I am afraid a little bit. And this is a quotation from Stanisław Lem, a very famous Polish SF writer, but he wrote it more than 50 years ago. Thank you very much.